And I think it's really important to have these conversations in small and large groups. Um, I will say that over the years, I've been doing the job that I do for over 20 years now, and my patients have inspired me in so many ways, but in the greatest way to talk about how prevention and screening can make such a big difference later in life. And that's not just true for prostate cancer, which I will focus on tonight, but even things like the major killers of men, heart attacks and strokes, are the result of years and years of a process in the body that, if recognized early, measures can be taken to prevent early death. I think everybody probably knows that men are dying at earlier age than women on average from pretty much everything except for Alzheimer's disease, but all cancer, um, and stroke and heart attack, lung diseases. So, one of the issues, one of the things I've come up against is I see a man in my clinic who has prostate cancer and is scared, um, and has a host of these other medical problems, diabetes, high blood pressure, high cholesterol, and the focus needs to be on the entire man and on preventing that patient from ever getting there in the first place. So I will focus, though, on prostate cancer specifically, um, for just as a matter of setting the stage. We know in the United States that men who are Black die from prostate cancer at a higher rate than all other ethnicities. Um, we don't know exactly why that is, but there is a higher rate of prostate cancer in Black men. And there's also a higher rate of death in prostate cancer in Black men. One of the reasons why we are having more and more trouble accessing and treating men who have prostate cancer, Black or white or brown, is the healthcare system itself. There is a reluctance to screen men for prostate cancer in some of the primary care communities and associations, based on some research that was done about 15 years ago that led to a recommendation on the national level against screening for prostate cancer. That was fairly baffling to all of us in our field. It was done with the right, I think, spirit, and that was that at that time, many men were being treated for prostate cancer who never needed to be treated. I'll talk about that a little bit later also. But in the process, the ones who really did need to be identified and treated, especially treated early, were lost, were neglected, and continue to die. And in fact, those death rates are increasing in the United States and disproportionately higher in Black men. So there's definitely a problem on the doctor side, on the medical side of things. However, there's, I think, also a major issue with patient engagement in their health if they're men. Men don't like to go to the doctor. They're busy. They've got better things to do. They've got other people to worry about. They're working, and it might interrupt their work. So men are very, very much less likely to go to doctors than their spouse, than their children, than their parents, and that needs to change also. What I have been promoting in communities around the state of North Carolina is for men, patients themselves, to advocate for their own testing. There's no substitute for insisting upon getting checked for prostate cancer, even if the doctor is reluctant to do it. It's just a blood test now. The blood test is called PSA. We are no longer mandating that a prostate exam be done. That was also a barrier that was causing men not to want to go to the doctor. And is also not as useful these days anymore. So a prostate exam is a finger in the rear end. And in many of the groups that I have met with before and discussed this with before, that has proven to be a major obstacle for men, and they won't go to the doctor as a result. So I say, let's just take it off the table and at least get people the blood test. The blood test is very useful in at least identifying who might be at an increased risk of having prostate cancer. In fact, we know that if a man gets a PSA blood test, and this is recommended by the American Cancer Society now, a PSA blood test before the age of 50, especially if he's Black or has a family history, which is a father or a sibling, and that test comes back as less than 1, that test is less than 1, that man has a really, really low chance of ever having a problem with prostate cancer for the rest of their lives. That would be really nice, because we can then say to those men, like, you don't need to be checked as much, if even ever again. That's the majority of the patients. Then there are some patients who have a PSA that is higher. And instead of thinking of PSA in the normal way that we are given the results now from the lab, which is abnormal is greater than 4, we can take a large number of men off the table right away, and then focus on the ones whose PSA is greater than 1. That way we can follow them more closely. Doesn't immediately mean doom if the PSA is greater than 1. It just means that we need to start having those conversations, and we need to monitor more closely, and we need to decide if we together, because we always do this in what we call shared decision making, together, whether we take it to the next level of evaluation.